As per the espen guidelines, should we use enteral or parenteral icosapentaenoic acid or docosahexaenoic acid? The recommendation 30 says that high doses of omega-3 enriched enteral nutrition formula should not be given by bolus administration. Recommendation 31 suggests enteral nutrition enriched with omega-3 fatty acids within nutritional doses can be administered. The recommendation 32 suggests that high doses of omega-3 enriched enteral formulas should not be given on a routine basis. And the parenteral lipid emulsions enriched with icosapentaenoic acid and docosahexaenoic acid, the dose is 0.1 to 0.2 gram per kg per day, can be provided in patients receiving parenteral nutrition.
Recommendation for strength, the class 1 recommendation.
Sir, most recommendations are strong recommendations. আলাদা করে মেনশন করা হবে, মানে পার্সেন্টেজ মেনশন করা আছে।
These can be given, may be given generally asked. And ওদের যে advantages গুলো, মানে তুমি এই বিষয় একটা ওকে সাপোর্ট দিছাম কি নাম বলছিস ওইসব আছে। But now there are actually shown clear outcome by this. এটা বারবার আমাদের আসছে যে একটা সময় ছিল যে আমরা স্পিড করতেই ভুলে যেতাম পেশেন্টকে প্রথম প্রতিদিন নিউজেও বুঝে নিতে হবে। So that was a neglected area. And study after study showed the level of malnutrition in patients admitted in hospital for 2 days ago. So, only focus on it. করতে হবে ওরাল থেকে বলে ভালো এন্টারাল ট্যাবলেট এন্টারাল পুরোনা পালেও প্রোটিনটা ইম্পর্টেন্ট আর তাহলে মাথায় তুমি যদি অ্যাক্সেস করতে না ইউজ করতে পারছো তাহলে ইউ বিকাম দ্য পারমানেন্ট প্রোটিন
স্যার ওটা আমি সামারাইজ করে লাস্টে বলে দেব
ঠিক না what I'm saying is so it is you have to give some feed but in this special feeds they cover and glutamine ke cover and taking cover all of them are actually show that they change outcomes. I mean, that is the message I want to convey.
So that was the 30 লেখা আছে either this formula should not be given by bolus. So what is the issue? Should not be given on a routine basis. A routine basis মানে recommendation বুঝতে পারছো recommendation stop the
স্যার espen guidelines এর যে রেকমেন্ডেশন গুলো আছে ওগুলো স্যার রেকমেন্ডেশন হিসেবে দিয়ে দেন তারপর আমি সামারাইজ করে দেব যে কিভাবে ফর্মুলেট ট্রেন করতে হবে
No, you're not saying it's also present over here. I will still there is a message that you need to carry. That is for you.
Should we use parenteral micronutrients and antioxidants in critically ill patients? The recommendation 34 suggests that to enable substrate metabolism, micronutrients, that is trace elements and vitamins, should be provided daily with parenteral nutrition. Recommendation 35 suggests antioxidants as high dose monotherapy should not be administered without proven deficiency. Recommendation 36 suggests in critically ill patients with measured low plasma levels of 25 hydroxyvitamin D less than 12.5 nanogram per ml or 50 nanogram millimole per liter, vitamin D3 can be supplemented. Recommendation 37 suggests that in critically ill patients with measured low plasma levels, 25 hydroxyvitamin D less than 12.5 nanogram per ml or 50 nanogram mole per liter, a high dose of vitamin D3, 5 lakhs unit as a single dose can be administered within a week after admission. Nutritional therapy in special conditions. These are the conditions where the enteral nutrition should be delayed. If shock is uncontrolled and the hemodynamic and tissue perfusion goals are not reached, whereas low dose enteral nutrition should be started as soon as the shock is controlled with fluids and vasopressors or anapros while remaining vigilant for the signs of bioischemia. The main complication here arises if the patient is in shock and if we initiate the enteral nutrition, that is the main complication is NOMI, that is non-occlusive mesenteric ischemia. In case of uncontrolled life-threatening hypoxemia, hypercapnia or acidosis, whereas enteral nutrition can be started in patients with stable hypoxemia and compensated or permissive hypercapnia and acidosis. In patients suffering from active upper GI bleeding, enteral nutrition can be started when the bleeding has stopped and no signs of rebleeding are observed. In patients with overt bowel ischemia, in patients with high output intestinal fistula, if reliable feeding access distal to the fistula is not achievable. in patients with abdominal compartment syndrome and if gastric volume is 500 ml per 6 hours. Low dose enteral nutrition should be administered in the following conditions in patients receiving therapeutic hypothermia and increasing the dose after URL. In patients with intra-abdominal hypertension without abdominal compartment syndrome, whereas temporary reduction or discontinuation of enteral nutrition should be considered when intra-abdominal pressure values further decrease under enteral nutrition. And in patients with acute liver failure, when acute immediately life-threatening metabolic derangements are controlled with or without liver support strategies independent of grade of encephalopathy. Early enteral nutrition should be performed in the following conditions in patients receiving ECMO, in patients with traumatic brain injury, in patients with stroke whether it is ischemic or hemorrhagic, in patients with spinal cord injury, in patients with severe acute pancreatitis, in patients after GI surgery, in patients after abdominal aortic surgery, in patients with abdominal trauma when the continuity of the GI tract is confirmed or restored, in patients receiving neuromuscular blocking agents, in patients managed in prone position, in patients with open abdomen, regardless of the presence of bowel sounds unless bowel ischemia or obstruction is suspected in patients with diarrhea. The special conditions which are not included in the ESICM recommendations are non-intubated and frail patients. In non-intubated patients not reaching the energy target with an oral diet, oral nutritional supplement should be considered first, followed by enteral nutrition. In non-intubated patients with dysphagia, texture adapted food can be considered. If swallowing is proven unsafe, enteral nutrition should be administered. In non-intubated patients with dysphagia and very high aspiration risk, post-pyloric enteral nutrition, if not possible, temporary parenteral nutrition during swallowing training with removed nasoenteral tube can be performed. Now, in adult critically patients with sepsis, does enteral nutrition compared to no nutrition improve the outcome? Or in adult critically ill patients with sepsis, does enteral nutrition compared to parenteral nutrition improve outcome? Early and progressive enteral nutrition should be used in septic patients after hemodynamic stabilization. If contraindicated, the enteral nutrition should be replaced by progressive parenteral nutrition. Critically ill patients with surgical complications after abdominal or esophageal surgery. In patients after abdominal or esophageal surgery, early enteral nutrition can be preferred over delayed enteral nutrition. In critically ill patients with surgical complications after abdominal or esophageal surgery and unable to eat orally, enteral nutrition rather than parenteral nutrition should be preferred unless discontinuity or obstruction of the GI tract or abdominal compartment syndrome is present. In case of unrepaired anastomotic leak, internal or external fistula, a feeding access distal to the defect should be aimed for to administer enteral nutrition. In the case of an unrepaired anastomotic leak, internal or external fistula, or if feeding access is not achieved, enteral nutrition should be withheld and parenteral nutrition should be commenced. In case of high output stoma or fistula, the appropriateness of time infusion or enteroclasis should be evaluated and performed if adequate. How should the head trauma patients be fed? Trauma patients should preferentially receive an early enteral nutrition instead of early parenteral nutrition. And obese patients, how should they be fed? Isocaloric protein diet can be administered to obese patients, preferentially guided by indirect calorimetric measurements and urinary nitrogen loss. In obese patients, energy intake should be guided by indirect calorimetry. Protein delivery should be guided by urinary nitrogen loss or lean body mass determination using CT or other tools. If indirect calorimetry is not available, energy intake can be based on adjusted body weight. If urinary nitrogen loss or lean body mass determination are not available, protein intake can be 1.3 gram per kg adjusted body weight per day. How should nutrition therapy be monitored during the ICU stay? The main goals of monitoring of nutrition therapy in the ICU are to assure that optimal nutrition support is planned and provided as prescribed regarding energy, protein and micronutrient targets, to prevent or detect any possible complication, to monitor response to feeding and detect refeeding, and to detect micronutrient deficiencies in patient categories at risk. What are the laboratory parameters which should be monitored? Number one is the glucose. Blood glucose should be measured initially after ICU admission or after artificial nutrition initiation and at least every 4 hours for the first 2 days in general. Insulin should be administered when the blood glucose levels exceed 10 mmol per liter. Electrolytes. Electrolytes like potassium, magnesium phosphate should be measured at least once daily for the first week. In patients with refeeding syndrome, hypophosphatemia that is less than 0.65 millimole per liter or a drop of more than 0.6 millimole per liter, electrolytes should be measured 2 to 3 times a day and supplemented if needed. In patients with refeeding hypophosphatemia, energy supply should be restricted for 48 hours and then gradually increase. The conclusion: medical nutrition therapy of the critically ill patient remains a challenge. Numerous published trials, however, have allowed us to improve the evaluation of the needs of the patients throughout their ICU stay, integrating with better understanding of the physiology. The absence of studies focused on the early or prolonged state does not allow us to fine-tune the prescription of nutrition in these conditions. ICU patients are a heterogeneous group and unique recommendation for every patient and situation cannot be suggested. Each diagnosis, each period of time, whether it is early, post-resuscitated, stabilized, long stay, and any concurrent complications must be taken into consideration. Nevertheless, these guidelines based on the best current knowledge and evidence provide a set of nutritional recommendations in most frequent clinical situations encountered in daily practice in the ICU.